Hi, everyone, again. I'm Joey. I'm one of the PGY3 Internal Medicine. I have the pleasure of talking about the IVC with all of you today. So let's just get started. Let me make sure the slides work. Okay, that's so there's no conflict of interest, obviously. So just to kind of briefly go over the physiology of what we're kind of looking for, especially in spontaneous patients when we assess the IVC, is to see how the variations in intrathoracic pressure actually affects the IVC diameter. With inspiration, we have increased negative intrathoracic pressure, which leads to increased capacity of the pulmonary veins and ultimately increases venous return. So this is why when we take a deep breath in, the IVC tends to collapse, leading to a reduced IVC diameter. On the other hand, on expiration, we have decreased venous return, and we would have increased right atrial pressure and increased IVC diameter in that standpoint. When we do the IVC assessment, this is kind of the location we typically go for. So we would have the probe marker towards the patient's head, either a phase array probe or the curvilinear probe. And we try to get into that junction where we're imaging the IVC, we're getting capture of the hepatic vein and also seeing it drain into the right atrium. And sometimes POCUS practitioners like to start with the subcostal view and kind of rotate from the 3 o'clock position back to the 12 to try to get this capture. And if successful, typically you would have an image sort of like this. So in this image, you would see sort of the horizontal large highway looking structure will be your IVC. The first exit off the highway will be your hepatic vein per se. I don't know if there's if you can see my mouse here. And then this will be the right atrium that it would drain into. So this is sort of the view that we typically try to aim for, in saying that this is a good image capture of the IVC that allows us to interpret the images. And the American Society of Echocardiography have proposed criteria on how to sort of make or estimate the right atrial pressure from the IVC measurements. And it would suggest, okay, if the IVC is greater than 2.1 centimeters and less than 50% collapsible, which is the bottom here, that would suggest an elevated right atrial pressure, about 15. If it's small and definitely collapsible more than 50%, that would be your normal right atrial pressure. And the gray zone is really this area where your measurements are intermediate, your collapsibility are intermediate, and the right atrial pressure will be sort of normal to intermittently elevated in that standpoint, where a lot more clinical context will be required to interpret what your measurements actually mean. And just a caveat here is that this still applies mostly to, this still applies to only spontaneously breathing patients to sort of apply these criteria. So I remember as a PGY1 or even earlier in medical school, we're often asked the question of let's do a great volume status assessment. And as a medical student, I think I would see the PGY1s kind of go to the POCUS machine and roll that into the patient exam room. They look like heroes doing the IVC, like, okay, the IVC is big. We don't think we need fluids, or the IVC is small. We don't think fluids really needed here. So it seems like, even entering residency or even before this POCUS block, it's like, hey, this seems pretty darn easy. Like we just go in there, image the IVC, get a measurement, estimate the right atrial pressure, and it seems like we can get a good understanding of the volume status assessment. And really, it wasn't until this rotation that I realized I've been interpreting or thinking things the wrong way, and that there is actually a lot of pitfalls that comes into play when we're trying to image the IVC and trying to make interpretations off the IVC measurements. And this is sort of just graphic from, if you follow basketball, then Shaq is a NBA player who often runs segments on bloopers in the NBA when people make mistakes. And this is my entry into talking about the common pitfalls of the IVC. And the pitfalls are more so kind of subdivided into 2 categories. So either the image capture isn't great or your interpretation is out of context. So with the image acquisition, there's kind of 4, the more major ones, where firstly, you mistake the air duct for the IVC. Secondly, the cylinder effect. Thirdly, the location of where you measure the IVC also matters, and also whether the patient is spontaneously breathing or ventilated, your interpretation is going to be different as well. And the good thing is, I think I made all these mistakes during my POCUS rotations, so all the images and clips shared will be real cases, real people, in the spirit of Judge Judy. So the first one would be the aorta versus the IVC. So even on my QPath feedback here for Dr. Yu to review, I even wrote question mark IVC because I was thinking about this structure sort of in the kind of in the middle of the field here where I don't confidently see the hepatic vein. I don't confidently see the right atrium where it's supposed to be draining in. And this sort of horizontal structure looks a little bit thickened. It's not really varying with inspiration and expiration. It's sort of just there maintaining a decent diameter. Although the aorta is supposed to be a little bit more, it could be, you can see some pulsatility through it too. I can't really call that as well, but the bottom line here in this with this clip is that I really can't say that this is the IVC for sure. And if I were to take measurements of this horizontal looking structure and make it into my interpretation, I would have made an error there for sure. So that's the first one, aorta versus the IVC. Secondly is the cylinder effect. And I think this is the simplest image to sort of illustrate this. So if we imagine the IVC as a cylinder, where we're aiming our ultrasound probe and kind of getting the image capture also matters. So if we were to be off center or off axis to the IVC, and we try to measure the diameter there, it could actually vary between on where we're actually sitting on the IVC when we, with the ultrasound probe cutting through that plane. And if we're off axis a little bit, the diameter might be less than the true diameter where we're versus when we're actually on axis. And this is important because sometimes with image capture, we could see, oh, we see a glimpse of the IVC patient breath and we're off plane, and that really suggests that we're kind of on axis, but get off axis when the patient's respiration changes our position. So another sort of case here where I do see the hepatic vein here. I do see this horizontal structure, which I'm saying, okay, I think this is IVC because it seems to be draining into the structure, which I would interpret as the right atrium. But you can see that the diameter sort of really fluctuates, and then I lose sort of the capture at the end there in terms of the IVC itself. So it seems like I'm kind of on axis, but falling off the cylinder a little bit there as well. So really not a tremendously great picture here. Ideally, we want to see a longer trajectory of the IVC when we're knowing that, okay, we have a pretty good slice to the cylinder, not falling off with each respiration. Thirdly, the location of the IVC measurement also matters. So the ASC guidelines in 2010, they suggested to measure the IVC diameter at the end expiration, just proximal to the junction of the hepatic veins that lie approximately 0.5 to 3 centimeters proximal to the junction between the right atrium and the IVC. So as you can imagine, even with, this is the clip from the beginning of our presentation here, if we were to measure the IVC at the blue arrow versus the red arrows versus the yellow arrows versus the green arrows, the diameter changes, and therefore kind of landmarking, making sure you're on axis and measuring at a consistent area, which by definition, but from the ASC would be sort of near the red arrow position, would be sort of the ideal location for IVC measurements to make things interpretable. And finally, whether the patient is spontaneously breathing or they're in the ICU and paralyzed also matters. So as we had said in the beginning with the physiology, the spontaneously breathing patient would have negative intrathoracic pressures when they're inspirating, so their IVC would collapse. Whereas on the other hand, paralyzed and fully ventilated patients in the ICU would have a bit of would have positive intrathoracic pressures because they're ventilator dependent. And with inspiration, IVC actually becomes distended rather than collapsed. Third category in which people are sort of in between, whether or not they're on BiPAP or they're on the ventilator, but they're triggering a bit of their own ventilations. The intrathoracic pressures there will be quite variable. And why I separated these three categories into colors is that we actually have some evidence to support IVC measurements and their interpretation in estimating the right atrial pressures in spontaneously breathing and the paralyzed and fully ventilated patients. But a third category where the patients are still triggering the breath, just not quite yet solid evidence to point us towards one way or the other. So the blue ones are sort of validated and the other ones are not quite yet. So other common pitfalls is really trying to interpret the IVC after you think you have a good measurement, and things that could actually lead to a smaller than sort of what will actually make the IVC smaller than it actually is would be things like having increased respiratory effort. Even as PGY1, I remember getting IVC measurements. I'll ask the patient, "Hey, like you want to take a deep breath in, take a deep breath out," and then seeing that IVC collapse and distend, I will take measurements from that. So that's not technically correct way to do things, because you will want to measure it with kind of spontaneous with tidal respirations rather than exaggerated inspiratory effort. So the inspiratory effort would kind of artificially collapse your IVC furthermore. And things that would cause some pressure on the IVC itself, like performing a Valsalva maneuver or having intra-abdominal hypertension, would also artificially sort of collapse the IVC, make it smaller than what it actually is. On the other hand, things that would make the IVC bigger would be sort of, this is more so the classic category that could really influence the IVC measurements, and that we have to think about would be things that basically increase the would increase the right ventricular pressure. So pulmonary hypertension, so you have increased right-sided pressures, tricuspid regurg or stenosis, or even RV failure would sort of feed all that pressure back to the back to the right atrium and cause the IVC to be distended. And obviously, if the patient doesn't have great respiratory effort, where their IVC is minimally varying during respirations, would cause the IVC to be smaller. So kind of on the other side of what we just talked about. So this leads into our discussion of when is the IVC potentially useful. So thinking back to the different categories we had back then, where patients are either spontaneously breathing, either they're ventilated, or kind of in between. So in these ventilated patients who are paralyzed, we actually have two studies from 2004 that were reviewed in 2016 by Lee AL, would be examining patients who are ventilated and paralyzed who present to the ICU with shock. And in these studies, basically the authors look for the sensibility of the IVC and to determine whether or not the patients would be fluid responsive. And typically what they did was their outcome was to measure whether or not there's a 15% increase in cardiac output with measurements with advanced cardiac POCUS maneuvers. And the fluid responsive, the fluid that they use is typically some sort of volume expander. So one study found that if the IVC were to be descended more than 12% with inspiration, then it has good positive predictive value of fluid responsiveness with 93%. And if it's less than that, it seems to indicate a decent negative predictive value as well. And in the other study, they sort of said that, okay, well, if it's greater than 18% from what they found that the likelihood ratio, positive likelihood ratio of 9 for fluid responsiveness, whereas the negative likelihood ratio of 0.11 is less sort of impressive than the positive likelihood ratio. So I guess in the review article, the overall impression is that if the sensibility is greater than 12 to 18%, the patient is likely to be fluid responsive and leading to a 15% increase in the cardiac output. In the non-ICU setting in which patients are spontaneously breathing, presenting with acute circulatory failure, and this is what the paper by Mueller AL were talking about, basically patients presenting with shock. And what they did was, again, to look at the collapsibility index of the IVC to see how much IVC varies between inspiration and expiration. And they found that the IVC collapsibility index was more than 40%. Then they actually have a positive likelihood ratio of 3.5 in terms of their fluid responsiveness. Again, the negative likelihood ratio is a little bit less impressive in this instance. Recently, there was a 2020 study published in the Annals of Intensive Care, in which they tried to standardize the location of IVC measurement to predict patients' fluid responsiveness. So this is going back to kind of talking about the pitfalls of where the IVC measurement can influence our determination of the patient's right atrial pressure. So in this study, the authors tried to determine what is the best location that corresponds with fluid responsiveness and presented it here. So they took 81 patients of sepsis who are spontaneously breathing, not on any sort of supports, who they took to standardize evaluate the patients through standardized breathing and non-standardized breathing. So non-standardized breathing patterns would be just kind of patient's own tidal respirations, whereas the standardized breathing conditions, what they define with basically quite intricate in terms of having devices that measure how much pressure the patients are exerting when they're inspiring and expiring, so that they can kind of standardize the measurements there. So a little bit complicated, but the outcome kind of more applies to real world scenarios would be kind of patients triggering their own breaths. So they determined that the best location for the IVC assessment is actually 4 centimeters caudal to the IVC RA junction. And they found that in this location, the fluid responsiveness was predicted with the best accuracy. So they separated their outcomes into CIVC non-standardized, which is kind of the real world scenario, I would say. And they found that if the collapsibility index here was greater than 33%, then that would translate to a positive likelihood ratio of 8.3 in predicting patients' fluid responsiveness. And then the standardized breathing patterns were even more impressive numbers there. But again, it's a little bit more complicated and not, I personally feel, that applicable to a real world scenario. And just to illustrate what the authors were trying to do, again, this is a graphic from their published study, is that they found that measuring the IVC between different sites at site 4, which is about 4 centimeters from the IVC atrium junction, had the best predictability of fluid responsiveness. So that being said, we'll move on to cases here to discuss sort of how to hopefully make good IVC interpretations. And again, these are all cases that I've encountered during my POCUS block this month. So in case 1, we have a gentleman who is 71, who comes in with 2-week history of nausea, vomiting, diarrhea from recent chemotherapy. His medical history is symptom for metastatic sigmoid adenocarcinoma, type 2 diabetes, previous stroke, AFib, and he has known reduced ejection fraction congestive heart failure with a previous estimate of his EF to be 20 to 25% a couple years ago. So far, his hospital stay has been complicated by acute kidney injury, and he has been receiving IV fluids so far. And prior to my assessment, the patient was seen in Emerge. He was afebrile, heart rate of 91, blood pressure on the softer side of 94/63, but he was breathing on his own and maintaining good oxygen saturations. So I began with the cardiac POCUS study, starting with the personal axis view. And even though he had a previously documented TTE of 20 to 25%, I actually thought that his systolic function here didn't look too bad. You can see the mitral valve approximating, extending into the left ventricle there quite well. And then the endocardial contractions of the ventricle is pretty good in kind of coming together. And looking at the personal short axis view, it seems like he may have regained some LV systolic function in between his measurement to when I saw him there. And some views are a little bit suboptimal. I do apologize for that. But this is the apical 4 chambers, sort of looking at the 4 chambers as well. I think it's probably more of a 5 chamber, given that the center is a little bit circular in some parts of the clip. But it seems to, if I was actually on axis, it seems that the RV size might be at least 2/3 of the LV size, which would suggest some RV dilatation. And this is the subcostal view, again, probably a little bit off axis here. And then moving into the IVC assessment. Sorry, this didn't autoplay. So this is a patient, again, we have here the IVC. We can see a glimpse of the vein draining into the right atrium. And so it seems like the IVC is quite collapsible when we're just visually looking at the IVC here. but kind of applying what we had learned from the recent study, I decided to sort of take some measurements through as well. So just a click. So kind of trying to measure 4 centimeters caudal from the RA-IVC junction, making sure that's perpendicular to the tube itself. And I took measurements at end expiration and also at end inspiration, just to see what the measurements allow us to calculate the classibility index here. So that's basically what I did here. And with any assessment after doing the cardio POCUS scan, went through to do a POCUS scan to complete cardiopulmonary assessment. And from the lung POCUS, to summarize, we didn't see any pleural effusions. We felt that there was some B-line predominance bilaterally with the basal sort of influence there. And we thought it would be unlikely due to pulmonary venous congestion due to the overall clinical and sonographic picture in which the patient had presented with decreased oral intake, hypovolemia, leading to his presentation to the ER. And with the measurements I took of the IVC, we calculated his classibility index to be about 56%. And the word I use modifies to kind of illustrate the 4 centimeter measurements instead of the 2010 ASC measurements that we typically utilize in clinical practice. And so the classibility index I calculated was 56%. And therefore, we felt that a patient is likely to be fluid responsive. And to the care team, we suggested more IV fluids for this patient. So case 2 is about a lady who was 51 years old who came into the ER with 3-day history of abdominal pain, vomiting, and diarrhea. She has a medical history significant for Crohn's disease, which is in remission. And she was hypertensive in the ER, which the care team felt that it could be sepsis, secondary to urosepsis or pyelonephritis. She was symptomatic from those aspects. Before I saw her in the ER, she had already received broad spectrum antibiotics, as well as 6 liters of IV fluids. Prior to the assessment, I retook her vitals and she was still afebrile, but the blood pressure was seen a little bit on the softer side again with a MAP of 74. But again, she was breathing on her own and maintaining good oxygenation. So again, starting off with the personal long axis view, again, the LV systolic function here appears to be quite normal. And the personal short axis view here, you can see that the LV again is contracting quite well, emptying a good a good amount of volume with each contraction. But we were wondering about whether or not there could be a bit of RV dilatation from this view, but maybe it was just the way that I was slicing the image. Going to the apical 4-chamber view. So from a size standpoint, the RV itself does not look to be more than 2/3 the size of the LV. So from this, we said, okay, the RV size is probably closer to normal as well. And moving on to the subcostal view, but suboptimal imaging here. Then moving into the IVC here. So again, confident this is the IVC because the diameter varies with inspiration. I can see a glimpse of the hepatic vein sort of diagonally draining into the IVC. The end of the right side of the image would be sort of the right atrium that's supposed to be draining in. So using the same principles as the previous case, I took measurements to sort of calculate the classibility index for this patient as well. So this is with end expiration, and inspiration, and also did a lung POCUS. And to summarize the findings, we found that the patient had bilateral alveolar interstitial syndrome, which was more prominent on the right side with some basal predominance. And before we did a POCUS study, I saw her in the morning. So in the previous evening, she had an X-ray that had only demonstrated some patchy opacities in the left lower lobe. So we felt that the interval changes seen on our POCUS study is concerning for development of possible early pulmonary venous congestion, as she had received 6 liters of IV fluids, and then she was about a 60-kilogram lady, so quite a bit of IV fluids for her. And from the measurements taken, we felt that the modified classibility index was 6.6%, which we felt that It's not to say that patient is not fluid responsive, but rather they're more fluid indeterminate in this instance. And given our findings in the lung POCUS with the interval development of alveolar interstitial syndrome, more prominent on the right side, as well as the clinical context in which she had already received 6 liters of IV fluids, we suggested to care team to maybe it's better to hold off on more IV fluids for this patient. Moving on to our third case. So this is a 56-year-old lady who had come in with a fever, worsening lower back pain, and she was, again, hypertensive on presentation. Her medical history is significant for hypertension. She had a PMR and a new diagnosis of joint cell arteritis. So the team looking after her felt that, again, this could be something related to infection versus adrenal insufficiency from her chronic steroid use. For management steps so far before I saw her was that they gave her, again, good antibiotics, kept her on her home dose of the prednisone, and she was given 4 liters of crystalloids and still remains on an infusion at 100 mils per hour when I saw her. Her vital signs for hemodynamically appears to be quite stable, and she was breathing on her own against achieving good oxygen saturations. So again, going through the images here in the personal long axis view, the LV systolic function appears quite normal. The LVOT chamber size is not too enlarged, and overall, it seems like things looked pretty okay in terms of the systolic function. Here is kind of the main conclusion we drew. We've applied some color Dopplers there. It might be a little bit difficult to sort of, I don't know if there's some image lag with the Zoom application, but overall, our conclusion from the color Dopplers here, in the previous image, was that there was no significant aortic regurg or stenosis. Here, we do feel that there was maybe a presence of mitral regurgitation, which we thought that there was an eccentric jet that comes through that could be representative of mitral regurg. Oh, you can add a little marker here. Okay, thank you, Dr. Yu. And this image, just for axis view, again, felt the LV function here was the main conclusion, and it seems that the systolic function is quite well. The septal motion is also seem to be normal and not bowing or flattening, which could be indicative of RV pressure or volume overload during systole and diastole, which we'll touch on later. And trying to get a capture of a bit of the tricuspid bell there to measure tricuspid regurgitation. Sort of a suboptimal capture, but we still felt that there was eccentric jets here that could represent presence of tricuspid regurgitation as well. So again, to conclude so far, probably no significant aortic stenosis or regurgitation, probably presence of MR, probably presence of TR as well. In the apical forward chamber view, again, this is probably a little bit foreshortened, meaning that the axis doesn't sort of present all 4 chambers as sort of a little bit more equal in size, although the heart itself is a little bit more circular, which could be indicative that I was off axis in this image as well. But again, the LV motion seems to be normal. The RV size, you can argue maybe it's 2/3, maybe it's less than 2/3. So probably normal to mildly dilated, but what I think we call it normal in the end. And this is, again, just to illustrate the mitral regurgitation, and in this apical view as well. Again, there's some regurgitant jets there that would suggest MR, which we had previously talked about. The TR capture wasn't as good as the other side. Moving into the subcostal view, again, a little bit off axis here for sure. And using this view is where I went into the IVC view. So this patient, if you just look at the visual assessment of the IVC, you can say, okay, maybe kind of near closer to the IVC right atrium junction, there seems to be some collapsibility there. And if we were to take the traditional measurements sort of just beside the hepatic vein, we could maybe demonstrate more than 50% collapsibility. And however, if you look sort of distal to that, if you go further down inferiorly to the IVC, you can see that the collapsibility there, it really doesn't seem to be quite a lot there. So what we did in this case was to sort of compare, okay, what can we conclude from the different locations of the measurements? So if we, again, to measure from the classic location just beside the hepatic vein, it's what we did here. So even from the numbers you saw 1.6, 0.8, you can see that there's almost 50% collapsibility. And the 1.6 centimeter measurements there really suggests, if we go back to the ASC criteria, which I talked about in the beginning of the presentation, it's really not significantly enlarged IVC as well. However, if we took the measurements from the modified collapsibility index, 4 centimeters from the junction, the variations or the collapsibility really wasn't as impressive as the previous location of measurement. Incorporating the findings on the lung POCUS, which we felt that it was a totally normal study, there was no pleural effusions, no suggestions of alveolar interstitial syndrome. This presents an interesting case where the typical IVC sort of assessment, in which we say this is less than 2.1 centimeters and 50% collapsible, estimating a normal right atrial pressure, it seems to sort of kind of take account of the modified collapsibility of the IVC in the modified portion, which was only 20%. We said that, okay, although in this instance, from the modified collapsibility, it seems like the fluid responsiveness was technically indeterminate. The clinical history here, in which the patient had presented with maybe a bit of hypolipemia and tension, in addition to incorporating the findings from the lung POCUS, and it was completely normal without profusions, we felt that overall the patient would still be fluid responsive in this case. So kind of the caveats here is to kind of recognize that the location of IVC measurement, again, going back to the pitfalls, really matters in sort of making conclusions, but the conclusions, again, have to take into account of the patient's clinical history, as well as the other aspects of the cardiopulmonary assessment to make the final call in sort of determining whether or not patient would be likely to be fluid responsive or less likely to be fluid responsive. And finally, with the last case here, we had a 73-year-old lady who came in with pneumosepsis, who was admitted to the ICU for vasopressors and BiPAP initially, and later transferred to the GIM ward. And she has past medical history significant for COPD, pulmonary hypertension, which she was already on tadalafil, obstructive sleep apnea, as well as coronary artery disease and hypothyroidism. So from this past medical history, we can already understand that this patient most likely has existing right heart dysfunction, given the COPD, the pulmonary hypertension. And the management steps she had received when we assessed her was prostacyclin antibiotics on her home puffers, getting a little bit of acetazolamide as well, and on electrolyte replacement due to multiple metabolic derangements she had so far in her care. And from a vital sign standpoint, she was on high flow oxygen, triggering her, again, spontaneously breathing, and hemodynamically quite stable when I saw her. So this is the personal long axis view, in which a little bit suboptimal sort of axis in which we can't really visualize the mitral valves that well. The aortic valve seems to be decently visualized, but from this, we kind of just progressed to other aspects because she was a very difficult assessment there. So incorporating the previous image as well as this one, without overall the LV functions appears to be normal, but I think that the main point here, although again, off axis, is that the RV is significantly enlarged, in which, or dilated, I should say, in which it appears to be larger than the LV itself. Although we weren't able to do a really good, or I wasn't able to do a really good personal short axis, which would be the typical image to interpret septal motion, we felt that in this image, there appeared to be septal flattening and bowing during diastole and systole. Again, probably a little bit harder to call on an apical four-chamber view, but even the motion of the septum here seems to be sort of abnormal and irregular. And even the sort of the atria the septum nerve seems to be really the RA, or sorry, it seems to be really pushing from the RA into the LA as well. The LA is quite collapsed. So from kind of these sort of interpretations here, we thought that the patient actually had evidence of septal flattening or bowing with diastole and systole. And just for everyone that I have learned so far, POCUS is that RV septal flattening during diastole suggests RV volume overload, whereas RV septal flattening during systole suggests RV pressure overload. So we feel like from these images, this seems to be the case during both systole and diastole, and therefore we think there's presence of both RV pressure and volume overload for this patient. This is just another image on the same axis. Subcostal view here again. I guess the RV here is significantly larger than the LV down low. And going into the IVC assessment itself. So I would say I was probably close to the true center of the axis, but again, going back to the pitfalls, the tube of the IVC seems to change a little bit with the respirations. Maybe I was just close to the center, but not quite there. But even if I were to take a measurement here with the sort of the standard IVC location just beside the hepatic vein, it's only 1.2 centimeters. And if we do sort of evaluate this patient with an IVC isolated assessment, in which we just go in there and measure the IVC, we would probably say, okay, this patient has 1.6 centimeters diameter for the IVC. From the motion itself, it doesn't seem to be all that collapsible, maybe less than 50% for sure. So the right atrial pressure here estimated would probably be about closer to 8 mmHg, which is it's determinate. But to take into the context that this patient actually has significant right heart failure or right heart dysfunction with signs of RV pressure and volume overload, although this small IVC seems to be non-collapsible at 1.6, we didn't think, and to kind of add into the findings on the lung POCUS, in which the B-line predominates diffusely, suggestive of possible pulmonary venous congestion, altogether, we felt that this patient actually needs aggressive IV diuresis. And this is a clinical scenario which might be quite kind of uncommon, but commonly encountered in management of these type of complex right heart dysfunction patients, in which the IVC assessment alone would definitely not be enough to kind of guide a clinical judgment because of their existing right heart function. Because if this patient, if we went by the IVC measurement alone, and we said, okay, this patient's now hypotensive, we might be inclined to give fluids, but the IV fluids in this instance would actually probably worsen things because there's existing RV pressure and volume overload, and that we had recommended IV diuresis in the end. So this is sort of to drive home the point that the POCUS findings or of the IVC assessment on its own really not sufficient, and the full cardiopulmonary assessment is required to make our best clinical judgment in the end. So that ties into my final thoughts. To summarize, many factors can confound the IVC assessment. In certain patient populations, IVC assessment may predict fluid responsiveness. And finally, as I've just talked about, the IVC analysis must be done with a comprehensive approach, and an isolated IVC assessment is not helpful. So I want to give special thanks to Dr. Yu for supervising me through this rotation, and to Dr. Mike Satin for reviewing many of my QPAP images as well. And thank you everyone for attending this presentation. I would welcome any feedback as well as any questions and comments.
Great job, Joey. I think you did a really good job kind of highlighting a lot of the salient points in regards to IVC assessment. I could probably ramble for another hour on top about my thoughts about IVC as well, but I won't do that. A couple things I did want to kind of slam home, because I think one of the biggest logical fallacies that people make is that they confuse the IVC right atrial pressure assessment with the IVC fluid responsiveness assessment. And so in that last case you were presenting, you said, okay, the IVC is small, so maybe someone would give fluids. But in reality, it didn't look like that patient had a significant amount of variability. And when using the IVC for fluid responsiveness, it's actually the variability. It's the, the 33% or the 44%, depending on the places you quoted, that has been validated. And so I think a lot of people confuse the two concepts and say, oh, the IVC is small, give fluids. Oh, the IVC is big, don't give fluids. But the 2.1 centimeter cutoff and the greater than or less than 50% is really only validated in kind of using that to estimate right atrial pressure, which then you could use to add to your tricuspid regurgitant gradients to give you an RVSP. And so on top of many of the other fallacies that I think you highlighted really well, and some of the other limitations, it's confusing the two concepts of fluid responsiveness and right atrial pressure assessment that I think makes the IVC a very nebulous thing for people to learn right off the bat, because they have a difficult time kind of separating those two things.
Great, thank you, Mike, for the feedback.
Maybe just to add to that too is, sorry, it's Melanie talking. Joy, that was a great presentation. And yeah, I just wanted to add that maybe fluid responsiveness is not always the same as fluid like appropriateness for the patient either. So just because they're fluid responsive doesn't always mean that we should be giving fluids. And that can also be another thing that people like you really stress, don't do it in isolation. And I agree, because you isolate it, like you look at that in isolation, you might say, yep, they're responding to fluids, let's go ahead, their blood pressure is low, and that might get them into more trouble. So fluid responsiveness definitely does not always equal appropriate for that patient.
Thank you.
Yeah, these are all excellent points. I find it very interesting that in our Canadian recommendations for internal medicine POCUS training, we actually did recommend IVC assessment to PGY1s and 3s outside of the full cardiac evaluation. So that's why I've always taken the umbrage to that, and so I've always tried to downplay the assessment of the IVC. But because I know that people are being taught the IVC, it's important to do it properly and to be able to look at the pitfalls properly and to be able to interpret it properly in the very nuanced clinical setting. So Joey, I think you did an excellent job highlighting all of that. Oh, I also see, I think Dr. Kane has her hand raised as well. Dr. Kane, did you have a question? You're on mute right now.
I'll jump in again then, because I have many other comments I could make because I was writing things down as we went. I think another, and it kind of relates to the cylindering problem. Another thing that people forget is that we assume that the IVC looks like this, that the IVC is a perfect circle. And so the thought is that, if we're measuring kind of right down the center, we should be seeing the changes with inspiration and expiration appropriately. But a lot of IVCs are probably kind of shaped like this, and they're not totally cylindrical. And there's evidence that suggests, as the right atrial pressure, as the the intravascular volume increases, probably the IVC looks more cylindrical. But when it is not, when you're intravascularly not replete, that you don't have the same tone in your veins to give you that circle. And so even though you might be seeing, a certain change in the IVC when you're measuring it this way with inspiration and expiration, it might not be the same as the change this way. And so there's a lot of emphasis in some of the newer literature to say that we should probably be looking at the IVC in short axis as well as in long axis, despite the fact that the previous studies and the ASC guidelines and everything talk about the longitudinal axis. A big reason for that is because in cardiac sonography, that is what you can access is the longitudinal view. Whereas in POCUS, we have the ability to not just look at the heart. And so you can take one of those probes and go to a lateral view, and you can look at the IVC in short axis as well. And so I think that that's something that I'm sure there'll be more literature coming down the road in regards to how that and assessing, distensibility or collapsibility of the IVC in short axis versus long axis, how that affects our ability to interpret fluid responsiveness and some of these other values.
Thanks, Mike, for sharing that.
Oh, hi, Joey. This is Kathleen. I just have a more simpler question. So when I've been doing IVC measurements, I've actually been measuring the diameter of the IVC like 1 to 2 centimeters from the RA junction. You're now saying that when we're doing that, we should be measuring like right after the hepatic vein.
Yeah, so going back to the ABC guidelines, they actually, it's kind of quite, I'll probably just exit out and show you. So they said that they wanted ideally the measurement to be 0.5 to 3 centimeters proximal to the junction between the right atrium and the IVC. So I guess it really depends on where you measure, but typically I think it ends up to be sort of just inferior to the hepatic vein there. I don't know if that Dr. Yu or Mike, you have any other thoughts on the matter?
Yeah, I mean, it typically that's the ideal, often used location that meets the 1 to 2 centimeter kind of guideline cutoff. But it just highlights the variability in the literature in regards to where to measure the IVC. The paper that you presented just now is really the only paper that has a standardized location for IVC measurement. Nobody has really done that, and the literature is all over the place in where you can measure, just as you highlighted in that picture over there. So it's Kathleen, I think whatever you were doing it right, because probably one study was doing whatever you did.
Okay, sounds good. And then it's like the same area when you're doing the collapsibility index as well. You're measuring it around that area too.
I mean, for the collapsibility?
Yeah, like you're measuring it around like the hepatic vein area.
Yeah, so if you were to, well, in the modified study that we had talked about earlier, it would be 4 centimeters. So I try to kind of measure 4 centimeters when they're with end inspiration and end expiration, sort of just to make sure I'm in the right locations, because the images can change quite significantly between between respirations. So then I kind of just measure and then get the sensibility, the collapsibility there.
Perfect, thank you.
Yeah.
I just wanted to say thank you for letting me observe today's presentation. It's extremely helpful. And I had a question for the group now, just in terms of the curriculum that you guys have developed. Are you advising the residents and the learners to go based on like 4 centimeters from the right atrium at this point when they do their measurements as a standard of care?
Well, maybe I'll comment on that, because I'll be honest, I think this is the first time that we've done this, mainly because we were researching an idea for the topic, and this relatively recent study came up, and I found it kind of interesting. I actually wasn't aware of it until now, so I thought it was quite interesting to have Joey try this out and to present a little bit more details about this study. I'll be honest, I personally would not advise this just yet. I think I would still recommend using the ASC-based guidelines just so that we can get a sense of the right atrial pressure when we're going to be checking for the RVSP, for example. Because I personally still would unlikely to be using the IVC as a measure for overall fluid responsiveness, fluid tolerance, or fluid appropriateness based on all the discussions that we've had so far. And I'm not sure, Mike, if you have any other thoughts on that. Sure you do.
I always do. Yeah, so that I've read that that one study a while back, and Joey, can you scroll back down to it, the one that talked about the 4 points? Yeah, so the 4 centimeters caudal to the IVC RA junction was studied for collapsibility index. Not for right atrial pressure assessment. So the ASC guideline for, where to measure, which is, the 0.5 to 3 centimeters proximal to the RA junction, which ends up being like where the hepatic vein comes off, is where you should technically probably be measuring if you wanted the most accurate right atrial pressure measurement. When does that matter? Like never. I really never care what the right atrial pressure is. It just doesn't.
RVSP, Mike.
Right, but if the tricuspid regurgitant, jet is super high, they have pulmonary hypertension. If it's not super high, they don't. So it doesn't change what I do at the bedside. So if I had to pick one place to measure, which I could spend a lot of time talking about anyway, but if I had to pick one place, I would say, from an internal medicine perspective and fluid responsiveness, because that's generally what people are trying to infer, they should probably doing the 4 centimeters. Now, that being said, as Jeff and Melanie have both mentioned, fluid responsiveness does not mean fluid tolerance. And I would argue, Joey, that in that last case, the IVC added, no value, because you have a patient that's on 70% or 90% with a big dilated RV. If you give that person fluids, you're just looking for trouble. Their blood pressure is fine. They're not on pressors. So is fluids a reasonable or appropriate option? What are you hoping to enhance? Nothing, because they're not hemodynamically unstable. Are they fluid tolerant? Absolutely not. So assessing fluid responsiveness is not actually a necessary question here. And that would be kind of how I would have, made my way to there. And so the IVC, whether it's 1.6 centimeters, whether it collapses, doesn't mean anything.
I've also seen scenarios where some people have used the IVC as an endpoint for diuresis, which for this case, once again, probably would not be a good idea. I think ongoing diuresis would be quite important to try to offload that RV even further. I wonder if there's anybody else with any other questions or comments. If not, we're approaching 1 o'clock, and I think
Great job, Joey.
okay. Thank you, Joey. Thanks everybody for joining us and for all the questions.
That was great. Thanks, Joey.
Take care.
Thanks everyone.
Joey, that was great.
Take care.